RN Link presents Myocardial Diseases webinar by Anne-Marie Gould and Christy Zielinski. Course objectives. Define the differences between myocardial ischemia, injury, and infarct. Understand the types of myocardial infarctions. Review the clinical indicators, signs, symptoms, underlying etiology, causes, diagnostic workup, treatment, associated with myocardial ischemia, injury, and infarctions. Review 3 different case scenarios for each condition. Outline the potential query opportunities for each condition. Discuss components of CABG procedure and review DRG assignments. Disclaimers. This material is designed and provided to communicate information about clinical documentation, coding, and compliance in an educational format and manner. The presenter is not providing or offering legal advice but, rather, practical and useful information and tools to achieve compliant results in the area of clinical documentation, data quality, and coding. Every reasonable effort has been taken to ensure that the educational information provided is accurate and useful. Applying best practice solutions and achieving results will vary in each hospital/facility and clinical situation. On the next slides, we will define myocardial ischemia, myocardial injury, and myocardial infarctions. We will also discuss signs and symptoms as well as treatment and risk factors. Myocardial ischemia, also called cardiac ischemia, occurs when blood flow to your heart is reduced, preventing the heart muscle from receiving enough oxygen. The reduced blood flow is usually the result of a partial or complete blockage of your coronary arteries, which can lead to a heart attack. Myocardial ischemia might also cause serious abnormal heart rhythms. Some people who have myocardial ischemia don't have any signs or symptoms, also called silent ischemia. Causes. Mainly CAD, coronary artery disease or ACS, and atherosclerotic heart disease, ASHD. Blood clot. Coronary artery spasm. You can see on the image how the blood flow is reduced if there is blockage in the artery. Signs and symptoms. When they do occur, the most common is chest pressure or pain, typically on the left side. It can be ischemic or non-ischemic. Neck or jaw pain. A fast heartbeat. Nausea and vomiting. Fatigue. Shoulder or arm pain. Shortness of breath when you are physically active. Sweating. Risk factors. Tobacco. Diabetes. High blood pressure. High blood cholesterol level. High blood triglyceride level. Obesity. Waist circumference. Lack of physical activity. Types of treatments. Supplementary oxygen. Medications. Aspirin, a daily aspirin or other blood thinner can reduce your risk of blood clots, which might help prevent blockage of your coronary arteries. Nitrates, these medications widen arteries, improving blood flow to and from your heart. Beta blockers, these medications help relax your heart muscle, slow your heartbeat and decrease blood pressure so blood can flow to your heart more easily. Calcium channel blockers, these medications relax and widen blood vessels, increasing blood flow in your heart. Cholesterol-lowering medications, these medications decrease the primary material that deposits on the coronary arteries. ACE, angiotensin-converting enzyme, inhibitors, these medications help relax blood vessels and lower blood pressure. Ranolazine, Ranexa, this medication helps relax your coronary arteries to ease angina. Myocardial injury is a new ICD-10 code and is a CC on fiscal year 2022. Elevated troponin levels, in the absence of criteria that would meet MI, should be documented as myocardial injury. Myocardial injury is defined by at least one cardiac troponin concentration above the 99th percentile upper reference limit, high-sensitivity cardiac troponin, HSCTN, normal values are below 14 Ing/L. It can be ischemic or non-ischemic. Ischemic myocardial injury, example is myocardial infarction, can be type 1 or type 2, requires at least one of the following forms of evidence of acute myocardial ischemia. Symptoms of myocardial ischemia: chest pain. New ischemic changes on electrocardiography. New ischemic regional wall motion abnormalities on cardiac imaging. Acute coronary thrombus on coronary angiography. Non-ischemic myocardial injury. Examples are CHF, anemia, hypotension, sepsis, shock. It can be acute or chronic. Acute: rise and/or fall of cardiac troponins concentrations exceeds the biological and/or analytical variation of the assay. Chronic: CTN result greater than the 99th percentile value without a rise and/or fall over a period of serial measurements, example, more than 8 hours. Normal range for troponin 1 is between 0 and 0.04 ng/ml. However, the high-sensitivity cardiac troponin, HSCTN, normal values are below 14 ng/L. Inpatient coders and CDS should consider the record carefully to determine if there is further evidence that would suggest not just a myocardial injury but rather a myocardial infarction. Furthermore, one must look at the clinical situation to determine if the myocardial injury could be attributed to an oxygen supply/demand mismatch. If so, then it would be appropriate to query whether the myocardial injury could be further specified as demand ischemia. Treatment: treat the underlying cause. Tabular index for myocardial injury. Below are the tabular modifications that will be made to accommodate the addition of this new code. Code first the underlying cause, if known and applicable, such as below. Excludes 1. Acute myocardial infarction, I-21, and injury of heart, S-26. Excludes 2. Other acute ischemic heart diseases, I-24. What is myocardial infarction? Myocardial infarction, also known as heart attack, happens when one or more areas of heart muscles don't get enough oxygen. This happens when blood flow to the heart muscle is blocked. Sometimes, a plaque can rupture and form clot that blocks blood flow. The interrupted blood flow can damage or destroy part of the heart muscle. It can be fatal, but treatment has improved dramatically over the years. It is crucial to call 911 if you think you might be having a heart attack. On the image on the right side, it gives you an illustration of how blocked artery can result to myocardial infarction. Signs and symptoms. Head, lightheadedness. Pain, discomforts and numbness in the arms, back, jaw, neck, between shoulders. Pain pressure, fullness or squeezing in the chest, lasts more than a few minutes or comes and goes. Cold sweat. Trouble breathing or shortness of breath. Upset stomach or urge to throw up. For women, tiredness, heartburn, cough, heart flutters or lose of appetite. Acute myocardial infarctions are one of the leading causes of death in the developed world, with prevalence approaching 3 million people worldwide, with more than 1 million deaths in the United States annually. Irreversible ischemic damage, injury, to the myocardium. Acute myocardial infarction can be divided into 2 categories. Non-ST elevation MI, STEMI. A non-STEMI heart attack does not show an elevated ST segment on an electrocardiogram. These types of heart attacks may not be as serious as the STEMI heart attack, but they are still heart attacks and result in heart muscle death. A non-STEMI should also be recognized quickly and is best treated by medications and early angioplasty and stenting. ST elevation MI, STEMI. If this test shows something called ST elevation, you are having a STEMI heart attack. This type of heart attack is typically caused by complete obstruction of a coronary artery, an artery that delivers blood to the heart. A STEMI needs to be recognized quickly and is best treated by emergency angioplasty and stenting. Types of myocardial infarction. Type 1 MI, spontaneous infarction due to plaque rupture. Type 2 MI, infarction secondary to ischemic imbalance, coronary vasospasm, profound anemia, hypotension. Type 3 MI, sudden cardiac death, usually occurs outside hospital setting. Type 4 AMI, infarction related to PCI procedure. Type 4 BMI, infarction related to stent thrombosis. Type 4 CMI, infarction related to restenosis greater than 50% after initial PCI procedure. Type 5 MI, infarction related to CABG procedure. This is an illustration about myocardial infarction, type 1 or type 2. Myocardial injury, elevated troponin level. Plus. Myocardial ischemia, inadequate O2 supply to myocardium, most common is CAD and evidence by symptoms, EKG changes or cardiac imaging. Equals to myocardial infarction, type 1 or type 2. What clinical indicators to look for during chart review for myocardial infractions? Signs and symptoms like chest pain, angina. This symptom can be mild and feel like discomfort or heaviness, or it can be severe and feel like crushing pain. It may start in your chest and spread, or radiate, to other areas like your left arm, or both arms, shoulder, neck, jaw, back or down toward your waist. Shortness of breath or trouble breathing. Nausea or stomach discomfort. Heart attacks can often be mistaken for indigestion. Heart palpitations. Anxiety or a feeling of impending doom. Sweating/diaphoresis. Feeling lightheaded, dizzy or passing out /syncope. Second clinical indicator to look for are diagnostic workups. History and symptoms. Cardiac biomarkers/enzymes. The American College of Cardiology/American Heart Association, ACC/AHA, and the European Society of Cardiology, ESC, guidelines recommend that cardiac biomarkers should be measured at presentation in patients with suspected MI, and that the only biomarker that is recommended to be used for the diagnosis of acute MI at this time is cardiac troponin due to its superior sensitivity and accuracy. Electrocardiography. The ECG is the most important tool in the initial evaluation and triage of patients in whom an acute coronary syndrome, ACS, such as MI, is suspected. It is confirmatory of the diagnosis in approximately 80% of cases. Echocardiogram. An echocardiogram is useful to generate a picture of the inside and outside of your heart. Angiogram. This test involves taking an X-ray after injecting a dye-like substance easily seen on an X-ray into your blood. This allows doctors to see areas with little or no blood flow. Heart computed tomography, CT, scan. This imaging test uses X-rays and computer processing to create a highly detailed scan of your heart. Heart MRI. This test uses a powerful magnetic field and computer processing to create an image of your heart. Nuclear heart scans. Similar to angiography, these scans use a radioactive dye injected into your blood. What sets them apart from an angiogram is that they use computer-enhanced methods like computed tomography, CT, or positron emission tomography, PET, scans. Next is to look for the treatments provided. Cardiac procedures. Angioplasty. Special tubing with an attached deflated balloon is threaded up to the coronary arteries. Angioplasty, laser. Similar to angioplasty except that the catheter has a laser tip that opens the blocked artery. Artificial heart valve surgery. Replaces an abnormal or diseased heart valve with a healthy one. Atherectomy. Similar to angioplasty except that the catheter has a rotating shaver on its tip to cut away plaque from the artery. Bypass surgery. Treats blocked heart arteries by creating new passages for blood to flow to your heart muscle. Cardiomyoplasty. An experimental procedure in which skeletal muscles are taken from a patient's back or abdomen. Heart transplant. Removes a diseased heart and replaces it with a donated healthy human heart. Minimally invasive heart surgery, an alternative to standard bypass surgery. Radiofrequency ablation. A catheter with an electrode at its tip is guided through the veins to the heart muscle to destroy carefully selected heart muscle cells in a very small area. Stent procedure. A stent is a wire mesh tube used to prop open an artery during angioplasty. Transmyocardial revascularization. TMR. A laser is used to drill a series of holes from the outside of the heart into the heart's pumping chamber. Treatments like supplementary oxygen, medications, anticoagulant, example aspirin, heparin, antiplatelet agent, example Plavix, thrombolytic, clot-busting, medications, example, TPA, Activase, antiarrhythmia medications, example amiodarone, pain medications, example is morphine. This can help alleviate chest pain. Angiotensin-converting enzyme, ACE, inhibitor, example Lotensin, Capitan, Vasotec. Angiotensin II receptor blocker, example is lisinopril. Beta blocker, examples are bisoprolol, Zabita, metoprolol. Combined alpha and beta blocker, example, Coreg. Calcium channel blocker, example diltiazem, verapamil. Cholesterol-lowering medications, example atorvastatin/Lipitor. Digitalis preparation, example digoxin. Diuretics, example Lasix. Vasodilator, example nitroglycerin. This slide is a chart on different types of myocardial disease with elevated troponins. If there is rise and fall of troponin, we need to find out if it is with ischemia. If with ischemia, it can be acute myocardial infarction. Now we need to find out if there is atherosclerosis and thrombus or oxygen supply and demand imbalance. If with atherosclerosis and thrombus, then it is type 1 MI. If with oxygen supply and demand imbalance, it is type 2 MI. However, if there is no ischemia, it is only acute myocardial injury like CHF and myocarditis. If the troponin is elevated but stable, it is chronic myocardial injury like structural heart disease and CKD. Query opportunities. If there are elevated troponins, usually 3 levels in 24 hours, and there are symptoms of chest pain, shortness of breath, chest pressure, or there are EKG changes or with positive stress test with evidence of plaque or thrombosis rupture, then we can query MI type 1 if not documented. However, if it is only oxygen supply and imbalance, then we can query for MI type 2. If there is elevated troponin but no symptoms or EKG changes or negative stress test, we can query for non-ischemic myocardial injury, non-traumatic. There are times that the doctor will document MI type 1 when it is actually type 2 or just non-ischemic myocardial injury, then we need to validate the diagnosis. If there is a cardiologist on the case, review what the cardiologist is documenting. If it is in conflict with what the primary doctor is documenting, we also need to query the primary doctor. Case scenarios. Case scenario number 1. An 89-year-old woman presented to the emergency department, ED, due to an unwitnessed fall. The patient was diagnosed with a urinary tract infection and treated with Bactrim. During the ED encounter, the patient became progressively more somnolent. Additional workup revealed elevated troponin level and intermittent atrial fibrillation. Order to start amiodarone 200 mg TID. Troponin levels are 0.50, 0.30, 0.10. The patient was admitted for further cardiology management. She never reported any chest pain, did not demonstrate electrocardiogram, ECG, changes, troponin levels stabilized. Potential queries. Non-ischemic myocardial injury. Clinical indicators, elevated troponin levels, no chest pain and no EKG changes. Treatment, Bactrim for UTI only. Coma. Clinical indicators, somnolent. Follow up the GCS, found usually on the nurse's notes, below 8 could be potential query for coma. Follow up for documentation like obtunded, non-responsive. Treatment, neuro checks, NGT feeding, assisted in all ADL. Paroxysmal atrial fibrillation, if less 7 days reverted back to normal sinus rhythm. Clinical indicators, intermittent atrial fibrillation. Follow up for documentation, back to normal sinus rhythm, reverted to normal sinus rhythm. Treatment, look for cortisone drip, cardioversion, digoxin, blood thinners. Query sample. Documentation in the medical record indicates that this patient diagnosed with a urinary tract infection. Other information in the medical records includes no chest pain and no EKG changes. Additional workup revealed elevated troponin level and intermittent atrial fibrillation. Troponin levels are 0.50, 0.30, 0.10. Treatment, cardiology consult, Bactrim, amiodarone 200 mg per TID. Based on your medical judgment, can you further clarify in the progress notes and/or discharge summary the most likely or suspected underlying cause for the elevated troponin, such as, include only those that may apply. Non-ischemic myocardial injury, non-traumatic. Clinically insignificant. Other cause, please specify. None of the above/not applicable. In responding to this request, please exercise your independent professional judgment. The fact that a question is asked does not imply that any particular diagnosis is desired or expected. Thank you. Mr. Salazar, a 57-year-old male, presents to the emergency department with chest pain. He reports that the pain started about an hour after dinner, while he was working. He describes the pain as a crushing pressure located mid-sternal and radiating down his left arm and to his back. He rates the pain a 4 out of 10. On assessment, Mr. Salazar is diaphoretic and pale and complains of shortness of breath. Upon further assessment, the patient has no jugular vein distension and no edema. His heart sounds are normal S1 and S2 and lungs are clear with scattered wheezes on auscultation. His vital signs were as follows: BP 140/90. SpO2, 90% on room air. Heart rate 92 and regular. Height 173 centimeters. Respiratory rate of 32. Weight 104 kilograms. Temp 36.9 degrees centigrade. His 12-lead EKG report reads, normal sinus rhythm with frequent premature ventricular contractions and 3 to 4 beat runs of ventricular tachycardia. ST segment elevation in leads 1, AVL, and V2 through V6, 3 to 4 mm. ST segment depression in leads 3 and AVF. High sensitive troponin levels, 240, 300, 450. The provider orders the following: aspirin 324 mg p.o. once, nitroglycerin 0.4 mg sublingual every 5 minutes for up to 3 doses, morphine 4 mg IV push PRN, unrelieved chest pain, oxygen to keep SpO2 greater than 92%. Potential queries for case number 2. 1. Acute myocardial infarction. Clinical indicators. Chest pain, crushing pressure located mid-sternal and radiating down his left arm and to his back. Diaphoretic and pale and complains of shortness of breath. EKG report reads, normal sinus rhythm with frequent premature ventricular contractions, and 3 to 4 beat runs of ventricular tachycardia. ST segment elevation in leads 1, AVL, and V2 through V6, 3 to 4 mm. ST segment depression in leads 3 and AVF. High sensitive troponin levels, 240, 300, 450. Treatment, aspirin 324 mg p.o. once daily, nitroglycerin 0.4 mg sublingual q 5 minutes for up to 3 doses, morphine 4 mg IV push PRN, unrelieved chest pain, oxygen to keep SpO2 greater than 92%. 2. Acute respiratory failure. Clinical indicators, SpO2 90% on room air, shortness of breath. Respiratory rate of 32, lungs are clear with scattered wheezes on auscultation, also review for documentation of respiratory distress. Treatment, oxygen to keep SpO2 greater than 92%. Query sample for case number 2. Documentation in the medical record indicates that this patient has been admitted with chest pain. Other information in the medical records includes chest pain, crushing pressure located mid-sternal and radiating down his left arm and to his back. Diaphoretic and pale and complains of shortness of breath. EKG report reads, normal sinus rhythm with frequent premature ventricular contractions and 3 to 4 beat runs of ventricular tachycardia. ST segment elevation in leads 1, AVL, and V2 through V6, 3 to 4 mm. ST segment depression in leads 3 and AVF. High sensitive troponin levels, 240, 300, 450. Treatment, aspirin 324 mg PO once daily, nitroglycerin 0.4 mg sublingual Q 5 minutes for up to 3 doses, morphine 4 mg IV PPRN unrelieved chest pain, oxygen to keep SpO2 greater than 92%. Based on your medical judgment, can you further clarify in the progress notes and/or discharge summary the most likely or suspected underlying cause for this condition, such as, include only those that may apply. Acute STEMI. Myocardial ischemia. Other cause, please specify. None of the above/not applicable. In responding to this request, please exercise your independent professional judgment. The fact that a question is asked does not imply that any particular diagnosis is desired or expected. Thank you. Case scenario number 3. 44-year-old male who was admitted for dizziness and noted blood in the stool. He is known to have alcohol abuse. Hemoglobin revealed 6 grams per dl and hematocrit revealed 20%. Stool for occult blood positive. His troponin level was 40, 55, 70. He was also complaining of chest discomfort and shortness of breath. EKG showed a normal sinus rhythm with occasional PVCs. MD ordered serial H&H, serial troponins, electrolytes and BUN and creatinine. He also ordered cardiology and GI consult, 3 units of blood transfusion, O2 at 2 liters. MD documented diagnoses of GI bleed. Cardiology consult done and documented, demand ischemia due to GI bleed. Potential queries for case number 3. 1. Acute MI type 1 or acute MI type 2 due to demand ischemia only. Clinical indicators. His troponin level was 40, 55, 70. Hemoglobin revealed 6 grams per dl and hematocrit revealed 20%. He was also complaining of chest discomfort and shortness of breath. Cardiology consultation done and documented, demand ischemia due to GI bleed. Treatment. Cardiology consultation. Blood transfusion. MD ordered serial H&H, serial troponins. 2. Acute blood loss anemia. Clinical indicators. Hemoglobin revealed 6 grams per dl and hematocrit revealed 20%. Blood in the stool. MD documented diagnoses of GI bleed. Treatment, blood transfusion, serial H&H. 3. Alcohol dependence. Documentation of alcohol abuse. Review for possible alcohol withdrawal signs and symptoms like tremors, hallucinations or delusions. Alcohol dependence or abuse with withdrawal is a CC. Query sample for case number 3. Documentation in the medical record indicates that this patient admitted for dizziness and noted blood in the stool. Other information in the medical records includes hemoglobin revealed 6 grams per dl and hematocrit revealed 20%. Stool for occult blood positive. His troponin level was 40, 55, 70. He was also complaining of chest discomfort and shortness of breath. EKG showed a normal sinus rhythm with occasional PVCs. Cardiology consultation done and documented, demand ischemia due to GI bleed. Treatment. Cardiology consultation. Blood transfusion. MD ordered serial H&H, serial troponins. Based on your medical judgment, can you further clarify in the progress notes and/or discharge summary the most likely or suspected underlying cause for the elevated troponin, such as, include only those that may apply. Non-ischemic myocardial injury, non-traumatic. Myocardial infarction type 2 due to demand ischemia. Demand ischemia only. Other cause, please specify. None of the above/not applicable. In responding to this request, please exercise your independent professional judgment. The fact that a question is asked does not imply that any particular diagnosis is desired or expected. Thank you. Case scenario number 4. A 62-year-old male with a personal medical history of CHF, myocardial infarction, CAD with 3 stents, ischemic cardiomyopathy, and CKD, is admitted for acutely decompensated chronic systolic CHF. He had no chest pain or other ischemic symptoms. The initial troponin level was 0.26, URL is less than 0.10, which slowly trended downward, 0.19, 0.15, 0.14. EKG reported ST and T-wave abnormality, consider inferolateral ischemia. The attending physician spoke with cardiology, who believed the troponin elevation was likely due to a combination of CKD and troponin leak from cardiac strain due to CHF. The attending MD documented troponin above reference range. Lasix 40 mg IV BID, cardiology consultation, serial creatinine, echocardiogram. Potential query for case number 4. 1. Non-ischemic myocardial injury. Clinical indicators. Initial troponin level was 0.26, URL less than 0.10, which slowly trended downward, 0.19, 0.15, 0.14. EKG reported ST and T-wave abnormality, consider inferolateral ischemia. Cardiologist believed the troponin elevation was likely due to a combination of CKD and troponin leak from cardiac strain due to CHF. The attending MD documented troponin above reference range. No further testing was done. Treatment: Lasix 40 mg IV BID, cardiology consultation, serial creatinine, echocardiogram. 2. CKD stage. Review if baseline creatinine is documented so it can be included in the clinical indicator list. Also check if there is nephrology consultation. Treatments may include serial creatinine levels, nephrology consultation, or renal diet. Query sample for case number 4. Documentation in the medical record indicates that this patient is admitted for acutely decompensated chronic systolic CHF. Other information in the medical records includes: initial troponin level was 0.26, URL less than 0.10, which slowly trended downward, 0.19, 0.15, 0.14. EKG reported ST and T-wave abnormality, consider inferolateral ischemia. Cardiologist believed the troponin elevation was likely due to a combination of CKD and troponin leak from cardiac strain due to CHF. The attending MD documented troponin above reference range. No further testing was done. Treatment: Lasix 40 mg IV BID, cardiology consultation, serial creatinine, echocardiogram. Based on your medical judgment, can you further clarify in the progress notes and/or discharge summary the most likely or suspected underlying cause for the elevated troponin, such as, include only those that may apply. Non-ischemic myocardial injury, non-traumatic. Myocardial infarction type 2 due to CHF and CKD. Demand ischemia only. Clinically insignificant. Unable to determine. In responding to this request, please exercise your independent professional judgment. The fact that a question is asked does not imply that any particular diagnosis is desired or expected. Thank you. Components of coronary revascularization procedure, CABG. Definition: bypass of native coronary arteries that have high-grade stenosis and/or occlusion, patients that are too high risk for PCI with stent insertion, acute myocardial infarction, severe 3-vessel disease. Components include high dose of heparin prior to initiation of procedure. Establish cardiopulmonary bypass to stop the native heart and drain the blood. Aorta is cross-clamped and cardioplegia occurs with a cardioplegic solution, may cool solutions and heart to enhance ischemic tolerance. Surgeon initiates bypass sequence, may include 1, 2, 3, or more vessels depending upon the severity of the heart disease. LIMA, left internal mammary artery, is typically used as a pedicled graft to the LAD, left anterior descending artery. Saphenous vein grafts may also be harvested for bypass vessel. Once anastomoses are completed, the aorta is unclamped, allowing coronary arteries to fill with oxygenated blood, and restores cardiac activity. High dose of heparin given at the beginning of the procedure is reversed with protamine. Lastly, the surgery team will monitor reperfusion of the heart for myocardial dysfunction, bradycardia, ventricular fibrillation, and treat accordingly. New CABG techniques, off-pump CABG, minimally invasive CABG. The illustration on the right side shows coronary blockages and how the bypasses are achieved. Complications that may arise from CABG: bleeding, stroke, organ dysfunction, dysrhythmias, postoperative atrial fibrillation, focal or global myocardial ischemia. Provider documentation must include name of each coronary vessel bypassed, equipment used intraoperatively, medications/IV fluids administered intraoperatively, EBL, complications, complete description of procedure performed. These are the references used for the webinar. Thank you for watching. Don't forget to click follow, subscribe and like buttons. For a fee, you can obtain 2 CEUs approved by BRN, AHIMA and ACDIS. Just click the link on the description below.